Deputy County Commissioner, Bale Sub-County in Western Region, and Ahmed Her, Deputy County Commissioner, Mombasa, to kindly come forward and lead us in a word of prayer. Commissioners.
Let us pray. Heavenly Father, this beautiful morning we want to thank you for bringing us together here safely. Thank you for journey mercies. Father, we want to thank you for today's deliberations. We want to thank you for our CSS that you have brought us together. Father, we invite you to be in our presence as we do all the day's deliberations. Father, continue blessing our country, protect our country, and bless all of us. Be for us today, for this is my humble prayer in Jesus' name.
Thank you. Let's pray. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الرحمن الرحيم. مالك يوم الدين. إياك نعبد وإياك نستعين. اهدنا الصراط المستقيم. صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. آمين.
Thank you, Commissioners. Kindly let's take our seats. Professor Kithure Kindiki, our Cabinet Secretary for Interior and National Administration. Dr. Deborah Baraza, our Cabinet Secretary for Health. Dr. Raymond Omolo, our Principal Secretary for Internal Security and National Administration. Harry Kimtai, our PS for Medical Services. Senior officials from both the Ministry of Interior and National Administration and Ministry of Health. Colleagues from the field regional commissioners and deputy county commissioners. Representation of the Director General, Kenya School of Government, distinguished ladies and gentlemen, good morning. Good morning once again. On behalf of the Joint Secretariat, let me take this opportunity to welcome you to our joint meeting between the Ministry of Health and Ministry of Interior and National Administration on universal health care coverage. Cabinet Secretaries, Sir and Madam, allow me to request the regional commissioners to do a round of introductions of the field officers here. We shall begin with Coast Region.
Good morning, sir. I'm Rodo Nyancha, Regional Commissioner Coast. I will request all the Deputy County Commissioners from Coast Region to be upstanding. Salute. Thank you, sir.
Sir, Coast has a total of 6 counties and 33 sub-counties. Northeastern.
Morning, sir. My name is John Otieno, the Regional Commissioner, Northeastern Region. Northeastern Region has 3 counties and 35 sub-counties. I would request the Deputy County Commissioners to be upstanding. Deputy County Commissioner, Northeastern. Salute. Thank you.
We proceed to Eastern Region.
Good morning, sir and madam. My name is Paul Rotich. I'm the Regional Commissioner, Eastern Region. Eastern Region, I have 72 sub-counties. I have all the Deputy County Commissioners with me, less for 6. They are attending some interviews at the Public Service Commission. DCCs, can you salute? Thank you, sir.
Thank you. Neighboring Central Region.
Good morning, sir. My name is Pius Mogambi Morogo, Acting Regional Commissioner for Central Region. Officers from Central Region, please be upstanding. Salute. Thank you so much, sir.
Thank you. We proceed to Rift Valley Region.
Morning, sir. My name is Dr. Abdi Hassan, Regional Commissioner, Rift Valley. I have 14 counties and 94 Deputy County Commissioners. Salute. Thank you.
Thank you. Nyanza Region. Nyanza has a total of 6 counties and 55 sub-counties. Officers, salute. Thank you. Western. Western has a total of 4 counties and 39 sub-counties. Salute. Thank you. And finally, last but not least, Nairobi.
Sir, my name is Kataya Mwanza, the Regional Commissioner, Nairobi. Nairobi has one county and 11 sub-counties. One of the DCCs is attending an interview, or she's already done with it. Salute. Thank you.
Thank you. Quickly, we also have officers from the ministry headquarters. Officers from the ministry headquarters, kindly be upstanding. Sir, they will not salute, but they are loyal. Kindly be seated. And finally, sir, I request my brother Adan Halake to be able to introduce officers from the Ministry of Health.
Thank you, Madam Opora. I want to write on the protocol laid by Madam Opora. I want to introduce the team from the Ministry of Health, and I'll request them to stand. There are few, we are lean. Thank you, you can sit down. They will not salute, they are loyal.
Thank you. Our cabinet secretaries, that's the composition of participants here today. And now, sir and madam, it's my singular pleasure and honor to invite the Principal Secretary, Internal Security and National Administration, Dr. Raymond Omolo, to proceed with the program. A round of applause for our Principal Secretary. Karibu, sir.
Thank you, Beverly. The CS for Interior and National Administration, Professor Kithure Kindiki. The CS for Health, Dr. Baraza Deborah. My PS colleague, Harry Kimtai, PS in charge of medical services. The Chairperson of the President's Council of Economic Affairs, Professor Ndi. The Deputy Government Spokesperson, Mwanaisha. The DG in charge of medical services, I think, yes, the Director General for Health, Dr. Moth. The CEO for Social Health Authority. Colleagues, ladies and gentlemen, good morning. Good morning once again. Now, I first of all must admit that I am excited when I look at the color in the room and the uniform and the faces and the energy and the fact that we've been able to stop everything within the national government administration at the sub-county level to come and have a conversation with our colleagues at the Ministry of Health as we plan the rollout of a very important program for the administration of President Ruto. Now, a week or so ago, we were having a conversation with the Ministry of Health and the relevant stakeholders and senior officers in government. And it became apparent that we were only having a few days to the official rollout of the universal healthcare coverage program, which is to begin on Tuesday next week. And there has been a lot of engagements, there's been a lot of interactions, there's been a lot of training, particularly within the Ministry of Health, all the way down to the community health promoters. And I know that even this week there is an ongoing engagement that is being undertaken. But then we realize that there is a critical component and a critical cadre of national government administration officers that were missing in that conversation and that engagement. And because of one of the greatest responsibility that this cadre of officers have in government, which is in terms of coordination of government programs and activities across the country, we were guided by His Excellency the President that we convene so that then we are taken through some of the critical components of this universal health coverage program. So today's program is going to be very elaborate, but at the same time very specific in terms of what is expected of all of you and all of us. So if you look at your program, you will notice that we have split the program into two sessions. So the first session would be to get remarks from our two cabinet secretaries, followed by a presentation by Professor Ndi, just to put things into context. Why universal health coverage? Why now? And how does it link with the government priorities as captured in the plan? Then we'll have a short health break. After that, we will go into the detailed presentations. First, beginning with the framework for the rollout plan, and also what we are expected to do in the entire rollout program and the implementation of the program. And then subsequently, then we will look at the benefit package, how the different packages have been profiled. And then, of course, lastly, we will look at what the targets are and the reporting structure. As we are here this morning, the enrollment is going on, and it will be good to know how far or how well we are doing so far with the enrollment, and what we must do between now and the 1st of October when the actual rollout begins, and what must happen going forward beyond the 1st of October. Also, to just put things into perspective, we have 8 regions administratively within the national government administration structure. The RCs had been introduced, but 2 of the regional commissioners walked in as we were finishing that process. The regional commissioner for Western, Mr. Irungu Masharia, thank you, and the regional commissioner for Nyanza, Madam Flora Moroa. We have 47 counties. For today, the county commissioners are not with us, but they will benefit from the discussions that we'll be having because they're part of the reporting mechanism. And then we have a total of 389 deputy county commissioners spread across in each of the regions and the 47 counties. And below the deputy county commissioners, we have the assistant county commissioners, and then below the assistant county commissioners, you have the chiefs, who are in close to 1,000 locations, and the assistant chiefs in 3,999 sub-locations. And below the assistant chiefs, who are at the sub-locations, you have the village elders, and we have in excess of 106,000 villages. And this marries closely with a close to, 107,000 community health promoters spread across the country. So you can already see that there's a very good nexus and a very good opportunity to be able to have a perfect and seamless linkage with our CHPs for purposes of us undertaking and rolling out this program. With those few remarks, allow me to invite the Cabinet Secretary responsible for Interior and National Administration to make his remarks, and then he will invite the CS for Health. Thank you.
Thank you, PS Raymond. My sister CS Deborah, the PSs who are here, Raymond and Harry, the chairperson of the President's Council of Economic Advisors, my brother David, all the senior officials from the Ministry of Interior, Ministry of Health, my colleagues from the field, good morning. I am also excited to be part of this historic event, and I must at the outset congratulate my sister Minister for Health and the team for the journey we have traveled until we have gotten where we are today. Universal health coverage is one of the key pillars of the manifesto of the Kenya Kwanza administration. And that's why David D is here to explain that what we are rolling out, or what we are about to roll out, is one of the key deliverables for this administration. There are 5 pillars, and universal health care is one of them. Secondly, I'm excited because the previous 2 administrations have struggled to implement universal health care, but unfortunately, because of other reasons, various reasons, it was not possible. The late 3rd President of Kenya, Mzee Kibaki, I remember that time the minister was a CS Charity Ngilu, had an attempt at universal health coverage. It was not possible, mainly because of resistance and other things, and misunderstanding of what it is. The immediate former president, Uhuru Kenyatta, also during his administration had a go at this very important exercise. Again, it did not pick up. I am persuaded that going by the very, very thorough background work that has been done by His Excellency the President, his economic team of advisors, the Ministry of Health, for the past 2 years, I am persuaded beyond doubt that this time round, the country has got this matter right. Number 3 is to mention that besides the preparatory work, the relevant law has been passed. The Primary Health Care Act, the Social Health Insurance Act, the Health Data Act, and therefore the legal framework which now anchors this program is in place, unlike in the past when the legal framework was not supportive of past initiatives. Therefore, we are at a good moment to implement one of the 5 main pillars of the Kenya Kwanza administration. We in the Ministry of Interior are very proud to be associated with this national endeavor. National government administration officers and the national government administration system exists to support government agenda in the grassroots across all functions of government. And that is why under Executive Order number 1 of 2023, the role of coordination of government functions across the country is vested with us through our Ngao teams. We have a national outreach right from Nairobi, from the headquarters to the regions, all the way to the villages. Every sublocation is headed by an assistant chief, and below the assistant chief we have village elders who now we are even integrating into the Ngao system to make them a formal part of this structure. We have approximately 106,000 village elders across the country, and then we have about 9,000 plus assistant chiefs, over 4,000 chiefs, and it goes on and on and on until you reach the region where we have 8 regions. So there is no other government machinery which can deliver this thing efficiently, fast, effectively, and at minimal cost. There isn't. Therefore, Waziri, even if I'm blowing my own trumpet, you must treat us well because we are enabling you to deliver. Now, Ngao is wired to do this kind of things. This is what we are wired to do. This is what the training of Ngao prepares this team to do, and the teams that are not here, the county commissioners and the teams below the DCCs. I am persuaded, just the same way we, through Ngao, supported very efficiently the registration of farmers for the distribution of fertilizer, where we enrolled over 6.5 million farmers in record time and saved the country hundreds of millions, or is it billions actually, which had been proposed by consultants. I am persuaded beyond doubt that we will deliver the registration of universal health coverage in record time and at minimum cost to the government of Kenya. We require, and that's why this meeting is important, as guided by His Excellency the President, we require these colleagues to understand the program in a simplified manner that can be consumed by the people of Kenya at the grassroots. What is it about? Why should everyone be part of this? What are the benefits? Why is it important? What does it save them from? And so forth and so on. Very basic information that can help the people of Kenya to enroll. CS has informed me that the target is about 12 million, and I think that's a very small target. We'll achieve it. And therefore, what we require from this meeting is very simplified information which can be consumed by the person at the grassroots who may not necessarily be sophisticated like the people in this room. Finally, this exercise will be done, of course, through the leadership and coordination of GAO officials, but with the cooperation and involvement of the 110,000 community health promoters who have been deployed by this same national government in partnership with county governments across the country, so that the exercise is seamless and is easier. And between the 106,000 elders and the 106,000 or 110,000 CHPs, I think this is a team that will deliver this thing in record time. And therefore, colleagues, ladies and gentlemen, I am very happy to be here today and to communicate on behalf of the Ministry of Interior that we are at the center of the registration campaign for the universal health coverage as part of our mandate in support of the Kenya Kwanza Administration Manifesto on Healthcare, and we are ready to go, and we will achieve the targets that will be set for us. And I want to say that these are the things that that we should be doing, okay? And therefore, even as the government looks at other aspects of the manifesto, anything that requires to be communicated to the grassroots in an easy way, in an authoritative way, in a manner that is persuasive to the public, will be more than willing to take on board so that we can support the government and support our country to succeed. And therefore, today is not my day. Mine was just to come and show my face and my presence. I think most of the technical and subject matter work will be done by the Ministry of Health. And at the end, my PS for Internal Security, Raymond, will be here to summarize and give the final word, if not the marching orders, so that we get started. In terms of the dates for the rollout for the program, the Minister of Health will communicate to us. Please support our colleagues in the ministry. Every regional commissioner will be responsible for their region. The returns from your region, which must be provided daily, will be your responsibility. Every county commissioner, the same. Every DCC, the same. And if we do this, the 12 million target will be met very easily. I'm told already about 1.6 million people have registered. So we are talking about 10.4 million in the next few weeks, so that every Kenyan can have access to primary health care, secondary health care, and also can be insured for purposes of treatment of critical illnesses, chronic diseases, and all these things that have impoverished so many families. Health expenditure out of pocket has impoverished millions of households in Kenya, and this is the solution. And going forward, Kenya is going to join the league of modern countries with a modern healthcare system where everybody accesses quality and affordable healthcare. With those many remarks, it's now my honor and privilege to invite my colleague, my sister, CS Deborah Barasa, to come and tell us what she wants us to do. Karibu Waziri.
Cabinet Secretary, Ministry of Interior and National Administration, Professor Kithure Kindiki, Principal Secretary Interior, Raymond Omolo, Principal Secretary State Department of Medical Services, Hariki Mtai, Director General for Health, Dr. Patrick Amoth, and President Council of Economic Advisor, Dr. Ndi, GAO, officials, ladies and gentlemen, good morning. Thank you. Let me start by sincerely thanking my colleague, CS Prof. Kithure Kindiki, for finding time to be here and also for mobilizing this wonderful team. And thank you so much, our GAO officials, for being here this morning. This is indeed a great demonstration of unity of purpose we share as a government. So, ladies and gentlemen, as you well know, we have had significant progress in the health sector. However, there are some key health outcomes which we have still not yet gotten the appropriate target. I love stories, and so I will tell you a story. So while working in the slums, some of the slums in Nairobi, I worked in Mathare, and I remember taking care of one person living with HIV. That was a widowed woman. Her husband had died from HIV, and she was left with 4 children. And she had developed complications in Mathare. So we had to, support her because she could not do her routine duty, which was washing clothes initially, as she took care of her children. But I remember one day when I sat with her, and she asked me one question, Daktari, ni dawa nitanunua, ni watoto nitasomesha, ni chakula nitanunua kwa nyumba, ni rent nitalipa, ama nitaenda Kenyatta kuonekana. And so that really touched me, and that is why we mobilized funds to support her. I also think of a 50-year-old man in the village who has that arthritis of his knee, and he has to rub Kaluma on that knee because he cannot afford to go to a facility and get appropriate services. He is energetic and he can take care of his family, but because of that knee pain, he cannot do that. I'm equally reminded of the patients who are on dialysis, and some of them, have had catastrophic expenditure. I remember even of a man I was seeing in Kenyatta who gathered his title deeds, gave his wife, told her, go and sell so that I can be treated. And seeing this man a year later, I wondered how much had he had to part with in order to get treatment. And once he's deprived of all this, then he will lose his life, you see, and leave his wife a widow and children without money. So these are real stories in our country. And with the Kenya Kwanza priority, that is the bottom-up economic transformation agenda, one of the priorities being universal health coverage. It resonates with me, and I believe it resonates with each one of you. Disease can come knocking at anyone's door. It does not know if you are elite or you are not. It can come at any time. And so universal healthcare coverage is critical for us so that each of us as Kenyans can be able to access affordable quality care. Okay? And so with the 4 pillars, one of them was the sustainable health financing mechanism, so that the Ministry of Health has a self-sufficient and autonomy in terms of finances, so that we can always have money and we are not depending on the exchequer for health service delivery. Equally, we'll be having a digital platform, and that would support in efficiency, transparency, and accountability, which is part of our national values. And also, we intend to have improved supply chain of the health products, meaning that madawa yafike mashinani effectively, and we are able to monitor so that each one of us can access the products, and equally the healthcare workers. And so in 2023, the Parliament enacted 4 laws upon which our UHC agenda is anchored: the Primary Health Care Act, the Social Health Insurance Act, Digital Health Act, and Facility Improvement. And we are currently at various stages of implementing these laws so that we can give Kenyans quality, affordable health care. And with regards to the social health insurance, Social Health Authority was formed, which will also be able to address these gaps. So I'd like to congratulate you, as Prof. Kithure Kindiki has said, regarding agriculture. 6.5 million farmers within 2 weeks. Please, let's give ourselves a hand of applause. Congratulations, congratulations. And I ask myself, how much more touching each Kenyan? The 12 million households that our Prof has clearly talked about. And so your support will touch each heart, each Kenyan heart. Yeah? It is indeed a privilege, an honor, an obligation for each one of us if all our people can access quality, affordable care. And so, ladies and gentlemen, all these changes we are making will be meaningless unless Kenyans know about them, number one, and two, take full advantage. The reason we are here today, because of the tremendous work, the tremendous experience, the good connection, the prompt sensitization that you have been able to do down at community level. We really need your expertise. We need to leverage on your platform so that we can sensitize, inform the community about the benefits, because there's a lot going on and they are not informed, so that they can know the benefits, they can register, and they are able to access affordable quality care. At community level, the message has not reached quite well. The coverage is not good. At the higher level, there's a lot of things going on in social media that may change the vision of Kenyans. They will not understand that this is for their benefit. We need you to inform them that SHA is for their benefit. They need to register so that they can access care. So we need you to support us in educating the public on their responsibility, and also for them to register in order to access care. So at this point, the priority, again, is to get all households registered and make contributions in readiness for 1st of October. So we kindly request that you engage through the village elders, chiefs, and community health promoters on SHA rollout. Share the message at every public forum as well, and you can present it in the barazas, funerals, weddings, school events, etc. You know your area, and I believe you'll be able to map out and action. So our target, as has been said, 60% of households, which means 12 million households. And so when you look at households, we expand to around 36 million Kenyans. And we hope we can achieve this by the 1st October. And so, ladies and gentlemen, what I'd like to say as I complete is indeed an honor, a privilege, and an obligation for me and for all of us as Kenyans to bring this home, to ensure that all Kenyans are able to access affordable quality care. And so please be ambassadors for the SHA and UHC, and we can take our country forward by ensuring that all Kenyans are able to access quality, affordable care without facing financial hardship as it is at the moment. So thank you, and God bless you.
I'm persuaded Waziri deserves a bigger round of applause. I think she's really personified the story, something you are able to relate with. And I'm sure each of us has some of those stories. And if we listened to her keenly, we need to try and do the same engagements across the country. Now, I want to invite Professor Ndi. Of course, we really want to make it as basic as possible, so that then we don't get it, we don't miss anything. But I think because of the history of where we have come from, right from the campaigns until now, the setup of all the 4 laws, it's important that we are able to get that connection well, and also the linkage with what the other better priorities are. So allow me to invite Dr. Ndi, who will speak to us. I think we are looking at about half an hour or thereabout. But anyway, yes. All right. And just try and put some of these difficult terms into perspective. Thank you. Karibu.
Thank you very much, Raymond, Mawaziri, Afia, and Interior, Kindiki, my good friend, DSS, Director General, CEO, all protocols observed. I am very privileged today. I have never been in a room with so many Kiraunis. So it's a first for me. It's a first for me I address many groups. I think I would like to get a very good photograph of this particular one. It is not my usual audience. Usually we see you know, out there where you are exercising statecraft, and we are sitting down. So to be here addressing you is, I think, quite a momentous occasion, and a very important occasion. My task is actually quite simple, because you being mashinani people, I think it is very easy for you to connect with why universal health care and access to health is important in the lives of people, as exemplified by the story that CS Deborah just told. So mine is really, I've been asked, I was tasked to connect the dots with our broader bottom-up economic transformation agenda. Why is health sitting there in our 5 pillars? We know health is important, but we don't think of it as economic. We think of it as social, perhaps. So why health sits among those economic pillars like agriculture and micro-enterprises and digital transformation and housing may at first look odd. But once I explain why it's sitting there, I think it will just emphasize and re-emphasize why it is so important, and that this is probably one of the most transformational and consequent initiatives that this administration will do, and potential legacy for President William Ruto for Kenya. So I will begin also with a bit of a story, but not quite a story. Kenya, there's a paradox. Our country is a bit of a paradox. When you look at our country, it looks very developed relative to relative speaking, to our neighbors and African countries. We are seen as one of Africa, a very sort of leading economies. We look very developed if you're in Nairobi. If you look at some of our statistics and parameters, investments, all sorts of things, it looks very developed. And physically, if you look at just visually, it really looks like an upper middle income country if you compare with many other countries. We also do not have the history of some of the challenges that many of other African countries have had. We haven't had political upheaval, conflict, coups. So we've been a relatively peaceful country since independence. and we look relatively developed. But when you look at the real development outcomes objectively, when you go to objective development outcomes, even within Africa, we are in the bottom half of real development outcomes. We have a very high incidence of poverty, which has been stuck at around 40%. Yet you see countries with much lower growth, much less human capital and all the other things, much better. I'll give an example. A country like, and talk about like, let's talk about like basic things like food security. If you go and check food security statistics around the world, we are bottom 20% in terms of food security. Or rather, we are one of the most food insecure countries, even in Africa. If you look at a country like Ghana, which has had coups, conflicts, all sorts of things, I think the population that is food insecure is less than 5%. In Kenya, 1 out of 5 Kenyans, 20% of the population, is chronically undernourished. Yeah? It's not a good statistic, particularly when you look at children. We hear a lot about economic growth all the time, but this growth does not seem to translate to prosperity for the majority. So there's a paradox there. A country which appears and has all the visible sort of, you can see the form of what you might call development, but you don't see the substance of it. So where is the disconnect between the form that you see and the substance? That story now connects me with President William Ruto. About 3 years ago, or 3.5 years ago, I had never met him. We had reached out, we had talked on the phone a couple of times, but I had never met him until 3 years ago, even in the same kind of political circles. And he was obviously going to run for president. So we sort of reached out to me and we had a conversation. And one of the first things he said in that conversation, and he reached out to me, is to say something. I think he said, you know, I have now accepted that there is something wrong with our economic model. Because we keep doing these things, we keep doing these development things as Jubilee. During Kibaki, we did many things. We thought we had transforming the country. Under Jubilee, we have done this, we have done all manner of things, build infrastructure. We thought we have been transforming the country, but we don't seem to have moved. Yeah? So, why is it that you have so much activity around development, but it is not translating to substantive change that among the people? Why is it that we've done so much, we've done invested, we've done Harambes for hospitals, we built level 5, level 6 hospitals. But when I look at my phone, it is full of Harambes for medical bills, or people sort of huge amount of distress, despite us doing all this development, among other things. The questions, issues I've said about food security. So, that conversation went on, and then sort of it continues today. Saying yes, there is something fundamentally wrong with our economic model, and that thing is called trickle-down economics. Trickle-down economics is an ideology that believes that prosperity is created at the top by a few people, and then it trickles down to the masses. Where did we get that ideology? We got that ideology from our colonial legacy. Because if you think about Kenya, our colonial state, and particularly as a settler colony, unlike other countries like Tanzania and others which are protectorates or an indirect rule, if you think about a settler colony, what the settlers did, the colonial did here, it came and created an enclave society around the settler economy. Yeah? An enclave around the settler economy, which essentially was to serve the settlers. Those of you out there in the countryside can begin to relate to what I'm saying. And so the people in that enclave economy, society, are those people associated with the state and the settler economy. Yeah? So if you are working in the administration like yourselves, or if the few people who are educated and you are required as a clerk or something like that, yeah, so you end up with a system which is like almost like a closed system for a few, and it leaves everybody else behind. Yeah? And if you look at all our institutions, that is the legacy of our institutions. These institutions are designed around a formal economy and structure. That's where it looks developed. But most of the people, the pastoralists and the fisher folk and all other people out there are not part of it. Yeah? So, what has happened over time, you start with that system. You have, at independence, a population of only 6 million people. It includes maybe only 1 million people are in that system. 5 million are out there as smallholder farmers and pastoralists and fisher folk. And 5 billion people can support themselves reasonably with the resources, land and other resources that are available. But when you get to 60 million people, it is very difficult to, that system cannot accommodate that many people, but it's very difficult to exclude 50 million people. And also the resources out there are not sufficient to support 50 million people. And at any rate, because of education and healthcare interventions, those people do not have expectations that they will remain pastoralists and smallholder farmers and fisher folk forever. Yet, the structure you have at the top isn't built to accommodate that many people. So you find that today, and I want to make this connection, we have a workforce of about 19 million people, and the economy we call private sector in Kenya, yeah? The economy we call private sector, what I'm calling trickle down, only employs 2 million people. The public sector employs another 1 million, so that's 3.5 million people. Those 3.5 million people, that leaves how many people? 16 million people. Who are those? They are uko mashinani, smallholder farmers, juakali, informal sector, in the micro and small enterprise sector. Now, our system is not designed, institutions are not designed to include those people. So let's take health. If you look at the health system that we inherited, it assumed that all those people would be catered for by public hospitals, dispensaries, and health centers out there. And then we created a health insurance only for employed people. So the NHIF was created primarily for people, because if you look at the way it is funded from payroll deductions. So if you are not on a payroll, you are you are outside the system. You don't need health insurance. Yours is to go to the dispensary for small infectious diseases. But if you have critical illness, you are on your own. Yeah? So, that was then when you had maybe 300,000 people in the formal wage employment when it was created. But over time, now you have a population and it has grown. So you find that you have then a healthcare system, if you come to Nairobi, where you have world-class healthcare in private hospitals. In fact, these are hospitals actually serve even the elites from the rest of the region. Yeah? That is where leaders from the rest of the region are evacuated. It serves international. It's good enough for the UN people who work here and all of that. But the ordinary Kenyan has a little dispensary, Uko, which hardly has drugs. They have to go there if they have just a small infectious disease, sit on a form, queue, go around, spend the entire morning, in which they sort of wasting their productivity, trying to get treatment for a simple infection or something like that. So, you find that even when we try to include people, and that's one of the conversations I'm having with William Ruto, is how he had tried to enroll people into the NHIF. But the problem is, because they are not on payroll, these people, NHIF then created a product for them called voluntary members. Where you pay 500 shillings per month. But a person who's not on payroll cannot remember to constantly be paying their 500 shillings. So they join, and after 2 months, they lapse. Then somebody gets sick and they remember, oh, I should have kept my NHIF current. So they have to wait, pay, and then now they try and access healthcare. What that causes is a problem where now the only people who are enrolled are the people who are sick. Because we call that in health economics adverse selection. So that you're only joining, yet an insurance is supposed to ensure everybody pulls money so that the actual cost, whatever is low, it doesn't work, it is not fit for purpose. So, you find the same. Think about Social Security, NSSF. It is only for people who are payroll. If you are out there, you are a mechanic in this country, even if you have a high income, there's no mechanism for you to easily save for retirement. The consequence of that is that you have then ended up with something, a very high, what do you call, a crisis of catastrophic health expenditure shocks. According to a study carried not too long ago, I think the data is about 2018 when you had research, it showed 1 million Kenyans in that year when that survey was carried fall into poverty because of a health shock. Somebody gets sick, okay, and when they get sick, then the household, because they don't have health insurance and they are not employed, so if you are an employee like yourselves, if somebody gets sick, even if it's yourself or somebody, one, you have a health cover, two, you get leave. You get sick leave, and you continue. So you covered in terms of health care, and you are on sick leave, so you are getting an income. Now, if you are self-employed, if you are in Jua Kali out there, self-employed as a Kenyan, what happens? One, you can't work. Yeah? Because nobody gives you leave from your kiosk. True? There's no leave from your kiosk, so you close your kiosk or whatever small business you are doing. Then you need to pay for health. So you take the money which was running the business. You take the working capital and it is consumed by illness. So 1 million Kenyans every year fall into poverty because of a health shock in the family. That's about 250,000 households out of a total of 12.5 million households. So, Kenya, poverty cannot go down. If you have 85% of your workforce is self-employed, and they are exposed to health shocks, yeah, it means that the health shock not only affects your health, it actually is financially catastrophic for that particular household. And if it is financially catastrophic, that is why even those businesses will not go. And that's why we get stuck. We get stuck treading water. Because people are trying to get in the health. So you are progressing, kidogo, you get sick. Or somebody gets sick. Then you sell the cow. Yeah? Once you sell the cow, you're back to, yeah. So, health expenditures, health shocks, is one of the biggest causes. Actually, it is the biggest, not one of the biggest. It's actually established. It is the biggest cause of business failure. It is the biggest cause of people falling into poverty, and it is the biggest cause of keeping poor people poor. And this is the scientific. Let me give you an example. Think about Nyanza and Western Lake region. Now, Lake region has very good land. It has high rainfall. Yeah, it has all for an agricultural country, it has high agricultural potential. Why does it have very high incidence of poverty? One thing only. Who can guess what it is? Why does the Lake region have a high incidence of poverty despite what is visibly a high agricultural potential? One thing only, even within ill health. Somebody is whispering the right thing. Malaria. High incidence of malaria. What does malaria do? One, you know about malaria is very high incidence. If you go there, you will find every other household has somebody who has malaria. True? Now, if somebody has malaria, they cannot work. Okay? Now, if that's a sort of bread earner, they are not working. You see, they are not given sick leave from their shop or from the farm. Okay? If it is planting season, you don't have the income even to buy inputs. Okay? Then that person probably needs somebody to care for them. So another person is the household workforce to take care of the sick person. Okay? You are taking, what does agriculture need? Labor. It needs labor. And so the resources of the household that are also needed for inputs and whatever. So that region suffers from a malaria poverty trap. Again, healthcare. So we sat down, as I said, and as we were discussing and narrowing down the things we needed to do with William Ruto, president, then he was candidate, health became very important. We said, then we must be able to take on this beast called health and make sure that everybody, and when you do the math, the statistics bear you out. These people will tell you, if you look at our total health expenditure, we spent, the last time, I think the last data we have, which is about 2 years ago, 150 billion shillings out of pocket health expenditure. Yeah? And that incident, it not only affects those people who are at the bottom, as we are talking about, because even people who are not every so often, because we are families, we have extended families, they are also being financed by other people. So it is taking money out of businesses, when we were talking to the cooperatives last week about this and providing finance for universal health care, for the onboarding people into shift, the cooperatives told us, SACCOs, in fact, we have been talking about this for a very long time. And we were even considered how we can start our own health insurance for SACCOs. Why did SACCOs think that they should consider starting health insurance? Can you guess? But why would SACCOs, why would that problem become so visible to SACCOs? Actually, the answer is the biggest reason for people liquidating their SACCO savings, or defaulting on their loans is health shocks. So somebody has put money in their SACCO, whatever, and they come and say, look, I need to cash out my SACCO. Why? Or my mom is sick, we need to take her to India. So we are whatever money the family, and the only money I have is the money in the SACCO. So SACCO begin asking, what can we do to? Because why else would there is other reasons you could persevere and say let keep savings. But if it is your own health or the health of your loved one, a spouse, a child, a parent, then I think that is a no choice situation. So you have sold one has sold the cow, you liquidate your SACCO, you sell the car, you can always buy that one later and deal with the health situation. So it's all around us. You can see the connection between, so even if we are trying to support agriculture, health shocks are pulling us down. You are trying to support small businesses, health shocks are pulling us down. Yet, the infrastructure we have, the only thing it can provide for people who are not on payroll, because it is a legacy system of that colonial structure I talk about, it could come up with was, we cannot determine these people's incomes, we don't know what they earn, so let's put a flat 500 bob. So whether somebody is a Juakali mechanic, or a rich businessman, all of you pay 500 shillings. So it is actually not, and that's because the system. So what we sat down, and we sat for a long time, is to try and figure out how can we design a system which is designed for our society as is. Not one which we are inheriting and just copy and paste from Western countries where everybody is employed by a big company, by a big organization. Because we are an economy of self-employed people. So we have to design a system which works for us. Not copy one, which we have tried to plug it in, people patch it up. In the end, we said, you know what, let us just put this thing there and start from scratch. So we sat down with Dr. Amoth here and other people and started thinking, how do we actually design? And perhaps this is the journey we should have started many, many years ago, saying how do we design institutions and structures and economic system which works for our economy the way it is. Not one which picks a few people and says the ones who are in suits and whatever, and design and just copy and paste the Western systems which can fit those people. Alafu hao wengine, the rest of the Kenyans who go fishing, hao watajipanga. Their lives are too complicated You try and fit them in this system, their lives are too complicated. One of the things which is really helping us to do that is digital. Because digital technologies now allow us to reach people, to connect people irrespective of where they are. Many of you remember, some of you, no, maybe not many, not as many. Sometimes we forget, some of us now are no longer vijana. And we are on the other side of whatever. But would remember when banking was only for the elite. For you to have a bank account, you are a very important person in society. Yeah? The ordinary people, they dealt with cash. Many of you remember when only senior officers in government or private sector had a telephone in the house. In fact, it used to be one or two people in the whole community, and the people who needed to make calls had to come and queue there to the person who owns a telephone. What digital technology has done is universalize these technologies. And now they enable us to leverage on this kind of technology so that you officers can onboard 6 million farmers onto a digital platform and enable us to deliver that fertilizer subsidy at the touch of a button. So he said, even in health, what enables us to now be able to universalize our healthcare system is to use leverage on that digital technology. Because digital technology does not discriminate whether you are informal, whether you are a pastoralist, whether you are, it doesn't discriminate. You are now able to connect, the connectivity with every Kenyan. You do not need to be in a formal institution for us to be able to plan and whatever. And we've already started in the healthcare. I think many of you will have interacted with the community health promoters. We have built that digital platform. It is now possible for this doctor sitting here to tell you today how many people have been visited by CHPs. They have taken their blood pressure and their blood sugar, and how many people have been referred for further investigation, potentially for diabetes or high blood pressure or hypertension. Now, that capability means that person, that old person who has, that parent or whoever, who has been investigated and for diabetes, that is probably a kidney disease averted. That person who has been investigated and referred for hypertension, it is heart disease averted. It's a heart disease averted. So with that capability then enable us to bring the quality of health care, world-class quality of health care to that person. In fact, probably better than many other places, including developed countries in the world. It allows us to begin to close that gap. So that is the opportunity, and not only opportunity, but imperative. Why this is so important? It is so important because in terms of healthcare cost, if you can avert that case of that person, and now we are moving to a case where society is also aging, so that you are shifting towards moving from a burden of infectious diseases to what these people here call non-communicable diseases. And once you move to non-communicable diseases, the kidney, the heart, the kidneys, all those cancers, the burden of catastrophic expenditures become even heavier. Very, very heavier. So it is very important that we take this action now. And we put everybody in one pool, one insured system, one provision system, because that burden, when that burden happens and that person needs to go to India and they need 5 million shillings, all of us have to I will have to put that money. And that money is we are taking out of other economic activity. The disease burden and the financial cost of that disease burden might actually overwhelm us economically. So we are not going to make economic progress until we solve our healthcare financing problem. Healthcare financing challenge. That is the message. So people are going to ask lots of questions. Why do we have to pay more for this social health insurance where we can get social health insurance, private health insurance somewhere else? That is the problem we have had in this country, where we have a small group of people who are able to provide for themselves in that enclave that I talked about of a small privileged economy. You think you have left everybody else behind. You think it is not your problem. But in fact, what it does is that it drags all of us down. It is keeping us down because you cannot leave behind 55 million people. You cannot have a prosperous economy. You cannot transform this economy and society by having only 2 million or 3 million people in the formal economy, with institutions designed around those people leaving behind the other 55 million Kenyans. I think that's the message that I hope we can be able to convey to everyone, so that we understand that we cannot leave anyone behind. It is counterproductive. It is defeatist. That is why we look developed, but we are not developed. So thank you very much for listening to me.
Let's give Prof another round of applause. So we will take a short break. There's a photo session outside, and then we come back immediately after that. Asanteni sana.